Thank you. It's a pleasure to be here this morning. So this is, I think, an exciting area, not just for post-procedural antithrombotic therapy, but also for long-term prevention in patients with peripheral artery disease. It's a rapidly evolving field. These are my disclosures. Antithrombotic therapy in this population is complicated. When we think of the coronary population, we debate about the intensity and the trade-off between ischemic risk reduction and bleeding. And I think in patients with peripheral artery disease, this is even more complicated. On the right side of the slide, we know that patients with PAD are at heightened risk of systemic events like ischemic stroke and myocardial infarction. But we also have to be concerned about progressive limb disease and whether there are agents that have efficacy to prevent that. And we have to worry about stent or graft patency after revascularization, and worry about events like acute limb ischemia, which threaten tissue loss. All of those favor an intensive strategy with novel agents. At the same time, several observational data sets have reported that patients with peripheral artery disease are at heightened bleeding risk. And this might be explained by some of the overlap with bleeding risk factors like advanced age, renal dysfunction, low body weight. And in addition, they get frequent procedures. And so how do you manage potent antithrombotics around procedures? And that may favor less intensive antithrombotic strategy. What we know, though, is that when a patient walks through the door with peripheral artery disease, not only do they have a high risk of ischemic stroke or myocardial infarction, but whether we look at real-world populations, this is the REACH registry on the left, or trial populations on the right, we see that their risk of limb loss or a limb-threatening event like acute limb ischemia is as likely as a stroke or myocardial infarction. And what's most likely to happen is that they will have progressive disease, limiting disease that requires that they have some sort of revascularization procedure, about 1 in 4 over 3 or 4 years in these two graphs. So when we think about antithrombotic strategies, we have to address all of these events. We can't just look at major adverse cardiovascular events. This is a cartoon looking at a platelet in a blood vessel, showing some of the targets for current therapies. Here on the platelet, you see thromboxane A2, the generation of which is inhibited by aspirin. There are older data that in meta-analyses show that aspirin reduces MACE risk in patients with symptomatic peripheral artery disease. There are also trials that show that it's not beneficial in those that are asymptomatic, and therefore there's a lot of debate about the utility of aspirin. There are the P2Y12 receptor antagonists. Here you see the generations of thienopyridines with the more potent, less variable agent prasugrel versus clopidogrel. And then we have ticagrelor, which is not a thienopyridine, but is a P2Y12 receptor antagonist. It's direct acting and it's reversible. And in the ACS setting has been shown to be superior in terms of reducing major adverse cardiovascular events and even mortality. Then we have the PAR1 receptor. The PAR1 receptor is expressed on platelets and several other tissues like inflammatory cells, vascular smooth muscle, and endothelial cells. And it's the receptor for thrombin, so that we know thrombin doesn't just play a role in the coagulation cascade. It's a potent cellular agonist, and it's one of the most potent activators of platelets. And so we have a class of agents now to block the PAR1 receptor. And finally, we have our anticoagulants, and there are several novel agents at varying doses that have been investigated. One question, I think particularly important after an intervention like this, is what are the data to support dual antiplatelet therapy with aspirin and clopidogrel? Actually, there's only one trial to look at this prospectively in patients with peripheral artery disease called CASPER. The results are here. This was after surgical bypass, below-the-knee bypass grafting, where patients were randomized to aspirin versus aspirin and clopidogrel for a broad composite of index graft occlusion, revasc, amputation, or death. And there was absolutely no benefit of dual antiplatelet therapy with clopidogrel. Of course, looking at the coronary bed, we still extrapolate from that. We use DAPT after stenting in the extremities, but we don't have a trial to show that it's efficacious, and it's unclear that clopidogrel is the optimal agent. Certainly, as monotherapy, clopidogrel looks better than aspirin and PAD, but as an adjunct or as a more potent strategy, it hasn't been shown to be effective. Now, the Euclid trial is ongoing and should report later this year, and that is looking at ticagrelor, again, a more potent agent, versus clopidogrel as monotherapy. And while this large and well-designed trial, it's run by Manesh Patel and Will Hyatt, while it's designed to look at MACE as a primary endpoint, there is a first secondary endpoint that's going to include acute limb ischemic events, and they'll be looking closely at post-intervention patency rates. And there are some data for ticagrelor that show off-target effects such as increasing circulating adenosine and so on, which may have beneficial remodeling effects in the periphery. We do have some clinical data with ticagrelor in patients with PAD. Pegasus TIMI 54 was a trial of patients with prior MI for long-term secondary prevention, and there were over 1,000 patients with peripheral artery disease. Overall in the trial, ticagrelor at either the 60 milligram dose, a lower dose, or the 90 milligram dose used in ACS reduced major adverse cardiovascular events. And when we look at the subgroup of patients with peripheral artery disease, we see that they not only were much higher risk than the rest of patients with prior MI, but they derived a greater absolute benefit with the number needed to treat of 25. And so in this population, it appeared to show those with prior MI and PAD a large magnitude of efficacy. And we, as an exploratory analysis, we looked at major adverse limb events with ticagrelor versus placebo, again on a background of aspirin. And you can see there was a significant reduction in acute limb ischemia, or the need for peripheral revascularization. And when you look at the components, you see the consistent trend for both. And so we have here a peak that ticagrelor may actually have benefit in the limbs, at least for thrombotic events, and we'll learn more from the Euclid trial. Bleeding, of course, is important. Here are the components of the primary endpoint and bleeding overall. Ticagrelor did increase bleeding, but in the subgroup with PAD, the increase with the 2 doses was modest, and so safety appeared to be reasonable in this subgroup. Now I want to talk about PAR1 as a target. As I said, PAR1 has many effects, including restenosis in animal models that in the setting of a PAR1 antagonist is blunted after balloon injury. In a large trial of patients with PAD or prior MI, it was shown to reduce the risk of systemic events, MI or stroke, when added to aspirin or aspirin and clopidogrel. It did increase bleeding, and when you look at the magnitude of bleeding increase, it was about 0.5% per year, even when added on top of aspirin and clopidogrel, similar to the magnitude of bleeding you get when you add clopidogrel to aspirin itself. And so, of course, a bleeding increase, no increase in fatal bleeding or ICH if you exclude patients with TIA or stroke. We also saw limb benefit with vorapaxar as PAR1 antagonist. For acute limb ischemia, there was a 42% reduction, and interestingly, there was a difference in all peripheral revascularization required. And when you look at the ALI events, you see that there's consistency for graft thrombosis, in situ thrombosis, stent thrombosis, and thromboembolic events, so consistent benefit across these etiologies. Interestingly, when you look at revascularizations, while we would expect an antithrombotic benefit for a PAR1 antagonist, we also saw a reduction in revascularization for claudication, chronic critical limb ischemia, and more markers of progressive disease, as well as consistent signal of benefit for the different types of revascularization. Now, for the last minute or so, just to touch on anticoagulants. Anticoagulants have been studied with vitamin K antagonists. They have shown not only no benefit, this was the WAVE trial, which looked at warfarin plus aspirin versus aspirin alone, no benefit for MACE or lower extremity ischemia, but really a marked increase in bleeding, over a 3-fold hazard for life-threatening bleeding. But that doesn't mean that anticoagulants aren't good. There are ongoing trials looking at very low doses of rivaroxaban, and there's a study, a small study of this, should be 200 patients, with edoxaban looking at patency. We did an exploratory analysis out of the Atlas ACS trial with low dose and very low dose rivaroxaban, looking at acute limb ischemia, and we saw a trend for benefit with both doses. And this has been taken forward into a study called Voyager, which is ongoing. So patients that are undergoing either surgical or endovascular revascularization being randomized to rivaroxaban 2.5 milligrams twice daily or placebo on a background of aspirin. So in summary, PAD is prevalent and is associated with poor outcomes, and acute or adverse limb events have to be a target for antithrombotic strategies. There are several intensive strategies that have shown benefit for MACE and male now, including the addition of a Parone antagonist or ticagrelor. And there are going to be more emerging strategies looking at our direct oral anticoagulants at variable doses. And so it's going to get more complex. We'll have to look at bleeding, but I think there's hope that we can modify these events with our antithrombotic strategies. Thank you.